So I'm delighted to be invited to this webinar and to tell you just a little bit about myself. I've been a geriatrician for over 35 years. And a geriatrician is just someone who specializes in taking care of older adults. I was trained as an internal medicine doctor before I did geriatrics. And when someone you love is in the hospital, as you all know, if you've experienced it up to this point, it's a very intense emotional experience, both for the person being hospitalized as well as somebody taking care of them. So I want to talk about all the kinds of things that you can do to both help yourself in this process and advocate and get the best information you possibly can, and also help the other clinical people take the best care of your loved one. And there are a couple of reasons for that, and I will explain it as we go along. So I will cover how you can help, how do you prepare, what do you do when they come home, and just keep track of all your questions. I'm sure lots of questions will come up and I can answer them at the end. You're taking someone to the hospital, or it even might be a 911 call. It's really important to be prepared and bring things that will really help the doctors be able to take the best care of your loved one. Medications are really, really, really important. And they can get very confused. If there are some records in the hospital and you've seen doctors before. So it's always a good idea to just put all the bottles that your person is taking and bring them with you. Even if you have a list, it's a really good idea, because then there's information on the bottles, who the doctor is that's prescribing them, where you get them, and that may or may not be very important. The other thing you want to always do is bring things that are really important for your person to be able to interact in the hospital, like hearing aids, eyeglasses, dentures. The reason why that's so important is that one of the risk factors as you get older, being in a hospital, and I'll talk about this in a little bit more detail, is getting confused, and the word is delirium. And what we found is if you can keep people sensory stimulated, keep their hearing intact, their vision intact, eating well, it really reduces the impact of delirium. In fact, what most clinicians should be telling all older people when they come in the hospital is to bring these things, because this is actually one of those evidence-based things that they study. Also, list of medical devices someone uses. We often forget this. Were they prescribed a walker or a cane? Do they have any braces? Do they have do they use oxygen? Were they supposed to use a CPAP machine? Those are the things that are obvious to me. There might be some other devices that are relevant to your person that you would want to include as well. Bring a pad and pen. So much goes on. I don't know if you've had the experience in the hospital. I know that I've talked to friends of mine who say, I say, well, what was the doctor's name? Or who is the person who told you this? And it's hard to remember everything. Things move fast. It's an emotionally charged time. So it's really good to have like a pad and a pen where you're writing everything down. Health insurance cards are useful. Not if you can't find them, that I wouldn't worry that much, but those are useful. Copy of a post or a durable power of attorney, or any kind of document that you and your loved one have discussed what their wishes for their care are. A post is usually in California, it's a pink form. I don't know if you've filled it out. One of the things I'd recommend is to have these conversations about goals of care and what people want before they're hospitalized, that's a whole nother talk. But if you've already done that and you have those, make sure you bring them with you. Bring your cell phone and charger. Some hospitals have chargers for people, but often you're there for a long time and the cell phone loses battery and there's not an accessible phone, and there'd be people who you want to call or who want to call you, and it's just a way for you to feel connected. And then snacks for yourself, because you're going to be there for quite a while in many cases. So that's just the first list of what to bring when you're on the way to the hospital. Okay, write down any questions you might have. Let's go to the next page, the next slide. This is really a little bit to expand what to bring to the hospital and what to communicate with the hospital for people with dementia or cognitive impairment. Make sure you let people know, if you do know that someone has dementia, or if you're concerned about that they have been over a long time, not acutely, but if over a long time they've had problems with thinking or memory, and it's a concern of yours, but you haven't had a diagnosis. If you do have someone who's been diagnosed with a dementia, you know, there is all sorts of ageism and implicit bias in medicine everywhere. And there are very enlightened people, but we're in an age right now that there's a lot of stress and pressure and time pressures in emergency rooms and hospitals. So these can be activated quite easily without people realizing it. So you can play a role, an important role in helping the hospital staff not see your person as someone who's a demented person, but who's an individual, and try to describe who they are, what they're about, what they like, so that when you're being evaluated, they're seeing your person as a whole person, not just a person with dementia who's confused. Also, if you know if there are certain behavioral issues with your person and that you know about, and you know what works and good ways to communicate, be specific and share that. And share it at every point that you're in the hospital. So when you're in the emergency room, share that. When you go up to if you're admitted into the floor, don't assume that all of this information that you've just shared with the emergency department is going to be transferred. Share it again with the nurse who comes and admits your person. Share it with the doctor. Behaviors that you know how to calm and comfort and how you do it will really, really help the staff. It also give them some things to try and give them some sense that they'll be able to deal with your person well. Explain the living situation, where they live. We're going to talk about this more, but are they living with you? Are they living in an assisted living? Can they live alone? Do they need caregivers? All the details of their living situation. That's very important for the people in the hospital to know. The other thing is, this is a stressful time for anyone, but somebody who has dementia or memory problems, processing all this new information is very, very stressful. And when someone has enough cognition, they can tell themselves, I'm in the hospital, this is going to be scary, I need to be here to feel better. But if you have significant dementia, you might not be able to reassure yourself that, even if you say that. But there are things that comfort people when they're in new situations. That could be music that's particular to that person. It could be a stuffed animal. It could be pictures of the family. It could be a particular pillow. So whatever that you know about your person really does tend to calm or comfort bring. So bring it with you. Let's go to the next slide. Now you're there, you've sort of done that, you have a list of things you've brought, and we haven't even gotten to when they start talking to you about what's wrong. But you want to know all the people you're talking to. I don't know if you've ever had the experience. There are a lot of people who come in. Often they tell you really fast. Sometimes they'll give you a card, sometimes they don't. So I really, really encourage you to make sure that whoever comes to talk to you, you ask them, who are they, what their role is, what they'll be doing with your person. So let's start with doctors. Most doctors do have a card. So if there's a physician that comes in, make sure you get their card. If they don't have a card, ask them for their name and phone number. Ask them what their specialty is. What are they doing there? Are they what's called a hospitalist, which are the doctors that take care of your person in the hospital? Are they the emergency room physician? Are they the cardiologist or heart doctor? Often doctors will ask lots of other doctors to see your person. Hopefully they'll communicate that with you clearly, but unfortunately, sometimes that doesn't happen. So it's really important for you to make sure you know who you're speaking to and how to reach them if you need to. Now, the other thing is there are a lot of doctors in hospitals, and a lot of the hospitals around here do have residency programs where they're training people. Kaiser does, Highland does. Sutter is actually developing a residency program, so they might not now, but they will. So you want to know the terms, because people come and say, hi, I'm the attending. And if you're not familiar with this culture, that's sort of a meaningless term. So the attending is basically the boss, is the doctor that's in charge of your person and is the ultimate decision maker. Then there's the fellows. Fellows are doctors that have finished their residency and are now training in a specialty. And often they're the first specialist you see in a place that has trainers. They'll come in, they'll introduce themselves as a doctor. They may or may not have a card. And they will then go talk to their attending, and often later in the day, they'll all come in. So a cardiology fellow is a doctor that's finished their residency training and is training in becoming a specialist. A resident can be an intern or a resident. Intern is the first year of post-medical school training. And resident, so they can be used interchangeably. Residents are anywhere from 1 to 3 years, if let's say in internal medicine, and it varies in different specialties. So you can have a resident in surgery, a resident in emergency medicine, a resident in internal medicine, and on and on. It's important to know if they're an intern or not and what year. You can ask. They may or may not have cards. Still write down their name and how to reach them. One of the things, particularly I'm giving this talk in August, this is the time where there are brand new residents. So it's just worth knowing that when you have an intern who's beginning working with your person in the summer, they've only been doing that a few weeks. Just an important thing to understand. And then many places have medical students. Often medical students spend the most time with your person and get the most thorough history. So you'll see nurses. You want to know if this is going to be your regular nurse or they change shift to shift. And if it's again, it depends on where you are, whether you're in the emergency room, on the floor. Primary nurses, many hospitals are trying to do that. And what that means is they're going to try to give the same nurse to your person every day that they're going to be there. Then there are lots of other clinical people who come see your person: physical therapists, speech therapists, occupational therapists, respiratory therapists, social workers. Again, make sure you know who they are. Now, if it's not, there's an obvious reason why you should know this, but different people are going to tell you different things, and sometimes you can be confused. Or you might want to say, well, the physical therapist told me this, and the speech therapist told me something else. So you want to clarify things with a doctor. And if you don't know who's you've been talking to, you might not get the best information that you want. So that's why it's so important to do this. And often doctors change a lot in the hospital. So you want to know if this doctor is a new doctor, if they've talked to the other doctor, so that you can get the best information, make sure that the information is flowing to the right people for the right things. Okay, so hopefully I've convinced you this is an important thing to do. And ultimately, I guarantee will be helpful, because it can be very confusing. Next slide. Okay, so this is about, doctors are going to take a history and they're going to ask you questions, and hopefully they'll get everything I'm going to tell you here. But one of the things I'd like to impress upon you is that as people age, things change in the way they present in illness. And unfortunately, believe it or not, there are only 7,000 geriatricians in our whole country. There's an estimated need for 41,000. And we're beginning to educate doctors and residents about geriatrics, but there is a lag of training. So the information that you give them, that I'm talking here, will help them do a better job, particularly if they don't ask. So some of this is obvious, like why did they come to the hospital? Be as specific as you can. And very important, how long were they sick? Were they sick just for 24 hours? Or have they been sick for a couple of weeks and slowly things are getting worse? Or were they sick a few weeks ago, got better, and then this new symptom arrived? So basically give them as much information as you can. Make sure that you tell them all of the medical problems that your loved one has. So here's an example of something you might need to do before preparing. We don't always know everything about the people in our life. So it's really a good idea to sit down and make a list of everything that's ever happened. I mean, I must admit, I'm a doctor, I go to the doctor and then I realize I forgot about this, I forgot about this, I forgot the year this happened. So I need to write everything down so I don't forget about things that may or may not be important, but they might be important. So it's much better to be as thorough as you possibly can. Again, I bring up medications. Medications we know that about 30 to 40% of hospital admissions are actually related in some way, shape, or form to medication issues. Either interactions or not taking them or taking them incorrectly. So make sure that while you're telling what the medications are, if you know that they forget to take them periodically, we all do. We all forget medicines. It's hard to take medicines regularly. Or if they have not taken certain things, or if they just started something, or they just stopped something. Those are really important things. Not all, they might not ask you that specificity, but it is really important that you let doctors know that. Also, what is their usual activity level? And are they normally independent, walking around? Do they do exercise? Do they basically do very little activity? Another that's also extremely important for people to know. Names, specialty, and phone numbers of all the physicians that you know they're seeing. That can be really helpful when something's not clear, or there's a diagnosis that's in question, or there's no past medical record in the hospital and they don't know what the treatment was. Having easy access for doctors and other healthcare professionals of other healthcare clinicians is really helpful and facilitates them getting that information quickly. And you can always ask, would it be helpful for me to get you any information? You know, and that's the beginning of learning how to partner with the people in the hospital. Okay, next slide. One of the other issues in hospitals is how being in bed, just being in the hospital, can produce all sorts of new problems. And continence and incontinence is extremely important for the people in the hospital to know. Is this something that is chronic? If they just became incontinent in the last few days while they're sick, that's very, very, very important to let people know, so that there's not the assumption that this is a long-term thing. The other issue, if they're normally continent, you want to try to prevent them from becoming incontinent in the hospital. So starting with a baseline, telling them they never had any trouble getting to the bathroom, and I'm hoping that that will persist is an important thing for the doctor to know. Now, another big issue with, as you get older, sometimes, you know, when people get older, they haven't read the textbooks about how they should present with an infection or a heart problem. Sometimes the only real changes are how they can take care of themselves. Or falling. That can, you know, someone fell, they haven't been eating for a few days. So it's extremely important to describe what their normal activity is when they're well. That when they were well, they could dress themselves. Or when they were well, they needed help with putting on their pants because of their arthritis. Or they were able to groom themselves with but they were not safe in the shower, and for the past year I've been needing to help them. Or they've been completely independent and they walk 2 miles a day, but the last few days they weren't able to walk. They usually normally use a cell phone well, but I've been noticing the past few days or the past 6 months they've been forgetting how to use it. Whatever it is, I'm just giving you examples. They used to do all the bills, but lately they haven't been, or they've been forgetting, or we've been getting late notices. They were able to drive, or they didn't drive. The past year, I've had to provide transportation, or they able to take the bus. So all the baseline self-care and how it's changed is very, very important, both for taking care of someone in the hospital, but where this is really important is also for diagnosis. Because sometimes this can show that there's a non-specific kind of presentation of what the illness is, and that these things are not chronic things. Again, people make quick decisions in the hospital. You know, that somebody, if they're sick and they're not being able to do their own self-care, that may be the way they always were. Let them know about their memory, if their memories had any problems or no problem. One of the reasons why giving a baseline about how they're thinking and confusion and memory is so important is because of the concept of delirium. Delirium is a type of confusion that happens in hospitalized older adults extremely frequently. If you're in the ICU, it's up to 80%, but in the hospital, it's somewhere between 30 to 60%, depending on what's wrong with you. And delirium can be very, very subtle to diagnose. And it's the way you notice it is someone seems confused, and it's predominant that they're not paying attention well. They get distracted easily. And this can actually change over the day, which is part of the diagnosis. So someone in the morning is fine, thinking well, no memory problems. In the evening gets very confused. And the reason why it's so important that you make these things clear to your nurses and physicians is that when there's some delirium has to be evaluated really thoroughly. And it's missed a lot by doctors and nurses, unfortunately. But family members can really highlight it. Like I remember I had a geriatric consult from a surgeon. Basically, this person was described as being completely intact, totally okay, and they wanted my advice on some specific things. And I went to the bedside, and I could have a good conversation with this person, and her daughter said, she's a bit confused. This is not, I mean, it's subtle, but she's not herself. And she had no cough. She had nothing else other than this confusion. As it turned out, she had a pneumonia. And we treated the pneumonia, and that she didn't have all the symptoms of the pneumonia. Her major symptom was being just a bit different. So then it was up to me to evaluate, was she delirious? And it was subtle, and then we worked it up. So that's why giving these baselines and noticing in the hospital what's happening with your loved one is so important. Now, another way to humanize our loved ones, particularly if they are confused, and also to show people that just because you're 80 years old doesn't mean you're necessarily whatever people's image is about 80-year-olds, is let them know the things that your loved one likes to do, their activities, their volunteers, hobbies. Here's another example of why it was so important. I was asked to see a patient. I was the chief of geriatrics and palliative care at Highland until recently. And so this was an inpatient consult. And they said, we need help managing this 92-year-old with dementia. So I try to get this history. This 92-year-old with dementia, which was all over the chart because she was confused in the hospital, had been a volunteer at Herrick Hospital 2 weeks ago. Now, you don't get dementia in a week. It just doesn't happen. So that knowing how she lived and what she did highlighted that this was this was not an accurate diagnosis. Also, it just helps people remember who people are, and it's a very important thing in the hospital to keep that alive. So hopefully you've given a good history. You have all the information. You've shared it with all the people who are taking histories. What information do you need to take good care of your person in the hospital? Well, what does the doctor think is wrong in all the diagnoses? And the reason why that's important and why I encourage you to write it down is because you're going to be seeing lots of people, and other people are going to give new information. And you want to understand what the working theories of what's going on with your person. And if there are other there might be multiple, they might have multiple diagnoses. For example, somebody comes in with an infection, they have a pneumonia, that's the diagnosis. But you also want to know, are they dehydrated? Is there any problem with their kidneys? Is there any problem with their electrolytes or other metabolic things? Those are all diagnoses. So the more you ask the doctor about what's wrong, the better you will be able to understand what happens as things go on. It also helps them communicate more thoroughly by asking those questions. are the doctors going to do to determine what they don't understand and what's going on? I'm sure you've gone to the hospital in some shape or form, and someone says, we're going to do a CAT scan or we're going to do an X-ray. And you're waiting and you're waiting. You might even be physically in the hospital and you're waiting for hours and you don't have the results. So it's always a good idea to ask people. And this also speaks to how you can develop good relationships with the people in the hospital. That's a place where we all want the results of the tests, and people are busy in the hospital. And so if you ask in advance who you should call and how they want you to handle this, it will help reduce friction with the people in the hospital that you're working with. Also, you can't always be in the hospital. Sometimes you're at work. You're going to be concerned about your loved one and you want to know what's going on. So ask in advance, who should you call? When should you call for an update? And what's the best way to do that? So you know how this particular hospital, this particular floor, everybody does these things differently. And then you can work with them and you'll get the best information. Also, what do you do when you're concerned? I mean, we all go to the hospital, we see things. And remember, what you see that you're concerned with will help people take the best care of your person. It's important to do this well in ways that people feel partnered with. So asking who and how do you call? Do you call the nurse? Do you call the floor clerk? You know, it'll be different in different contexts. What I want to talk about is how, there's a whole, being an advocate in the hospital and talking to medical professionals and partnering with them is really, really critical to getting good care. And since COVID, I mean, this was always true, but the stress level in the whole healthcare system, and I think in our society, has bumped up a notch. I mean, that's only one of the myriad of things that I think is stressing people out. So the healthcare system has felt a lot of stress, and there's a lot of pressure and time pressure of medical professionals. So learning how to partner and being sensitive to that at the same time as still being an advocate will help you be a good advocate and actually get people to be more open and willing to help you. It's like any kind of, it's sort of, what is the, you can, with honey, what's that expression? I forgot, I'm blanking on that expression.
You get more with honey than with,
catch more flies with honey. Yeah.
Right. And that's really important, because people in the hospital are also stressed, and often they really do want to be the best communicators and they want to give you what you need, and they're not always as aware of their, where they haven't. So the first thing to do is to make sure that you think about that you're in a partnership, and you can even say that to people, I really want to work with you to take the best care of my person. And you can ask, what does that look like for you? Also, just getting to know people in the hospital in your own way helps. Being warm, asking how they are, all the things that we do to create good connections with people is important in high stress situations. It's important for you, but it's also important for the people who you work with, because people we're all reactive to all things that we're not as attentive to. And if you're very anxious and scared and you feel like, I don't have it right now to take care of somebody else, which is sometimes how we feel, it is reasonable to say, I just want you to know that I'm really scared. you know, and I really appreciate you as a nurse, but I just want you to know how I'm feeling right now. So don't take it personally. You know, just talk to people. It's a very powerful thing and can really make your role as advocate when you want to bring up things much better. Be aware of your own stress and take care of it. You know, eat, go get a cup of coffee if you need to take a rest. It's important for you. It's really hard. As they say, if you're going to take care of someone else, you also have to take care of yourself. Now, I'm going to be very honest. There are egos in the hospital, and people don't always like being told things. Particularly doctors don't always like having things brought up. So a lot of being aware of that doesn't mean you shouldn't bring things up. In fact, I think it's really critical that you bring things up when you're concerned, because you know your person probably better than anybody else, and you're going to notice subtleties. And again, as people age, subtle changes are really important for clinicians to see and know. So I'm just letting you know to recognize that. And that when you talk to people, if you feel that, there are ways to deal with that, which is sometimes just saying one approach. And the reason I give you this is to say, I just wanted to share this with you. If you're feeling that kind of resistance, I took a webinar with a geriatrician who gave us all these things that we were supposed to tell you. So I'm really sharing this with you to be helpful. So to put it outside of the interpersonal thing, say you're following a professional's advice to help the doctors in the hospital. That often really does work, and it calms people down, because then they don't feel like you're challenging their skill. And also, when you want to bring stuff up, it never hurts saying, doctor, nurse, whoever it is, I so appreciate the care you've been giving my person, and I have noticed some things. Can I share them with you? So that's where I'm saying, use your own interpersonal creativity. I mean, you know, you have relationships, you know what works, you know your strengths, your weaknesses. And it really helps, because when people feel connected to you, as you all know, they listen better. And what you have to say to healthcare professionals is really important. And that's part of one of the biggest things of this talk, is to show you all the ways that that's true. So you're in the hospital, you've given the history, you've learned how to do, you know, call and talk, and the mechanistic ways to deal with people. You've made relationships. What should you be paying attention to? And what are the things that often goes missed in older people that are very important to let clinicians know? Let's start with eating. It is actually important to eat when you're sick and in the hospital. Often, though, for reasons that I can't really tell you why, probably it's staffing and communication issues, but it's really not good to eat in bed unless there is a true medical reason. Like if you've broken a hip and you have to have the leg a certain way, then you really need to be upright 90 degrees. It's much better to eat in a chair. And there's a bunch of reasons. One, it is one of those evidence-based ways to prevent delirium. So to prevent the confusion that we're worried about developing in the hospital. It also maintains strength. Being in bed for 3 days in the hospital, you can lose 40 to 50% of your muscle strength. So it's better to prevent as much deconditioning as possible, and sitting in a chair really makes a difference. It also, think about eating. Gravity helps getting the food down into your stomach. And when you're sick and you're older, things don't work quite as well, and aspiration of food is not that uncommon in the hospital and can cause a pneumonia. So these are all important things. Often doctors don't order it, people are busy, they don't do it. That's something you can be an advocate for. Now, the other thing is you can advocate with your person saying how important it is. And it's a counterintuitive thing, because we think when you're sick, you should be pampered and stay in bed, right? I mean, we all sort of were taught that. But when you're aging, it's one of the worst things you can do. Early mobility is the term that is used, but getting out of bed as much as possible and walking is one of the biggest preventions of delirium. Now, why do I care so much about preventing delirium? Because once someone's delirious, there's consequences. Other things happen. They have, when you're confused, you don't eat as much. You can be scared. You can have agitation. You can get other medical problems. And in the long term, delirium is associated with more confusion. So it can affect a long-term memory and thinking. But preventing it is really, really, really important. So eating in a chair, unless there's a medical reason not to, which is actually quite unusual. Toileting, another thing, getting up to go to the bathroom. People often need help to do that, but if they are on a schedule and the nurses assist them, or they can do it on their own, it can prevent incontinence and skin problems in the hospital. It's also another way to mobilize and get people moving. So it also keeps strength up. Bowel movements. Another thing that is actually quite important to keep whatever the normal schedule is. When people, it's very common to get constipated in a hospital because people are lying in bed, they're not moving, and they might not be eating and drinking enough fluid. And as you get older, if you don't drink enough fluid, it's very easy to get constipated. So this is something you can pay attention to. You'd hope that nurses would pay good attention to this. Some places they do, some places that's not always the case. So it's something you can do. If their normal movements is every third day, that's fine. But if it's every day and on the second day, nothing's happening, you'd want to talk to the nurse, because there's always orders to do something about constipation. Getting your person to drink fluids, unless there's special dietary restrictions because of swallowing problems, is something else you can do, because people also get dehydrated in the hospital very easily. And dehydration is another one of those things that can cause delirium. And when people are constipated, it can be a vicious cycle, because when you're constipated, you can just feel bad. And you're already not feeling well because you're in the hospital. But it can also decrease appetite. It can cause abdominal cramps. So these are all things you can have a big role in preventing. Sleep. Anybody who's been in a hospital knows sleep is a rare commodity, and often people are awakened all night long. So, there are times that's really, really necessary and important, but not always. And it's something doctors don't think about. So you can ask the doctor, can we let my person sleep through the night? Do they have to be awakened? And they might say yes. The first night, yes, but if everything gets better, no, in the future. So you can remind people. And doctors can write orders. Please do not awaken for vitals at night. Also, can you schedule medicines? So sometimes schedules are just because that's when something's ordered. It doesn't have to be given at 4 a.m. If somebody thinks about it, can be scheduled so someone isn't awakened. Letting people have good sleep in the hospital also tends to prevent delirium. These are all things that you can have a big role in, and also help your person heal faster. Okay, next slide. New confusion. So these are the things to call the doctor. I've been mentioning delirium over, because it's very common and very important. So even mild, and if you notice that they're not confused in the morning, they're confused in the evening, and then they're better in the morning, that is actually very significant, because the nature of delirium is it fluctuates, and somebody can be totally okay and then confused. So that's something you really want to let your nurse or doctor know. People come into the hospital with pain. If the pain isn't controlled, if they give pain medicines and in an hour it's still as bad as it was, let someone know. Functional change. Remember, we talked about how important it was to give someone a baseline of what, and for you to know as well. You come to the hospital and somebody can't feed themselves, and they normally can. That's important to let someone know. Or they could take their hearing aids in and out, and now they can't. Or any symptom that they've come in is getting worse, not better. Or any new serious symptom. Those are things you should let the nurse and doctor know. And I would let both, the nurse can be the first person, and if there's no response, and you're worried, you've already asked the doctor. Remember, this is an example of where it really helps. You ask the doctor, if I'm worried about something, what should I do? And if the doctor says, call the nurse, and if that doesn't, call me, and they give you your card, you can do that. So you've already gotten the instructions of how to handle this. They've gotten better, and they're going to come home, and they're giving you discharge. Make sure that you really understand everything that they've written down before you leave the hospital. And if you don't, ask the nurse to be very clear and specific. Medications can be very confusing. Make sure you know which of the old medicines to continue, if there are any that you should stop. And if there are new medicines, what are the things you need to be worried about? Are there side effects that you need to let someone know? Somebody came in, let's say somebody was in the hospital with a heart attack. Everything's okay. They don't have any chest pain. They have no shortness of breath. You want to know what things could happen that you need to call the doctor. The doctor might say, and unfortunately, that's not a routine. That's not always given. Sometimes it is, sometimes it isn't. If he has any chest pain, you should do this. Keep moving. Part of getting better is rehabbing and dealing with the muscle strength loss that's inevitable in the hospital. Sometimes you need home health. Home health is not always used. Medicare and Medi-Cal cover home health. Home health can send a physical therapist, an occupational therapist. They can actually send an aide to help you bathe someone while they're there. If you feel you need more help at home, talk to the discharge planner and let them know, because there are things that can be done. And if the person doesn't need physical therapy, encourage them to keep moving and not staying in bed. Make sure all the appointments that you need, if they tell you to have an appointment with your doctor, make sure you can get one, because everybody's very busy. I've had patients be discharged from the hospital, told to see their cardiologist in a week, and the cardiologist won't give them an appointment for 2 months. You don't want to deal with that kind of stress at home. You want to do it where there are people who can help you. So now, there's probably a lot more you want to know. I hope this was useful, and so why don't we just go to questions?
Great. Yeah. I want to ask you, Dr. Landau, how do you get help making appointments? Do you get the staff at the hospital to help you with that? I thought that was a good point there that you ended on. Can they help you with that? That sounds scary and daunting.
Okay, so that's one of the things that actually I should have put it, talk with the discharge planner. When the discharge planner comes, that's the person to talk to. Now, a lot of it depends on the system you're in. Every system is different. So Kaiser, if you're in Kaiser, yes, you usually can get the hospital people to make appointments. If, let's say you've gone to the hospital, you've seen a cardiologist, you never had a cardiologist before. So the cardiology team should be able to help you get an appointment. And so have the discharge planner say, can you call this cardiology team to make sure I can get an appointment?
Great. Yeah, you know, there's a couple of chats with specific questions, and I think if people want to get their questions answered, it's good to put it in the chat. That's sort of a good way to organize this.
Yeah, okay, I see that. That's a good. What do you do? I'll read them out loud. What do you do when you feel that the doctors or staff aren't really listening to you or don't have the time to take with you? So I would start with, how can I say this? Sometimes doing those preparatory conversations alerts them to what you need and they're more careful. And I've seen that happen. So by saying, I want to partner with you, I want to get information, how do I get it? Doing all the reason why I put all that in there is because often doing that makes the doctors more conscious that they have to do it. So often doing those things can help, but I don't want to pretend that's always the case.
And also, Dr. Landau, it may be that you have a new staff, new doctor.
Right.
Doctor went on vacation or whatever it is, and you tried to lay down the groundwork for a good relationship, but now you have, you know, what if you can't?
Right.
You know, for that kind of reason, or any reason.
So there's a couple of things I would do. The first I would do is I would try to ask the doctor to come and sit down and tell them that in a nice way. I'm really concerned. There are things that I want to communicate that I feel worried aren't being heard. And I would actually say that, first of all, it's an education for doctors. You know, people need feedback when they don't do a good job. That's not your job, but it's still an important thing. Sometimes that works. I mean, I'm thinking of witnessing when patients have done that. People will slow down, sit down, and try to improve their communication. Let's say that doesn't work, and you do it with the nurse as well. Then I would ask to speak to the nurse supervisor, not the charge nurse. This is, oh, I should have put that into the nurses, who the nurses are. There's the floor nurse. There's a charge nurse who's in charge of that shift. And then there's a nursing supervisor, which is the more senior person who's in charge of the whole floor. And you can usually call a nursing supervisor with the operator. You don't always have to go through a nurse. You can get on the phone and say, I want to speak to the nursing supervisor. I would tell them your concerns, that you're feeling that people are not listening, you're concerned about the person, you're not having good dialogues, and they are often the person who can facilitate that. Having said that, if that doesn't work, almost every hospital has some kind of patient advocacy office. Some are more accessible than others, and they're often called different things. But they usually give you, since Medicare now wants people to have a good experience, hospitals have to have this office, so they usually give you something to with a number to call if you're not having success. Okay, next question. Was that helpful? Did that answer?
I think that was great. I think there's a lot of concern about that issue. I think those are really good suggestions.
How long should doctor visit be? Sometimes they act rushed and just sending patients to lab tests. And okay, so you've just hit on basically this is one of the things we have to change in medicine. It is a mess, and it is true that I think doctors are rushed and they don't give you enough time. What I can say about that, the better you prepare for a visit, writing every single thing down you're worried about, the more you do the legwork and give it to them, the better you're going to get out of that time. Personally, what I want to really, I mean, that's something I care a lot about, but this is a systems issue. That's the best I can tell you of how you can get the most out of a bad situation. Okay, so what about if my person has a family listed on the post, but I'm not listed on? Can I have any info? All you have to do, if you want, your person can tell, I want you to give information to all of these people. So have them write down on a piece of paper, I want that my friend, my partner, my daughter is not on pulse, but I want all information to be given, and you hand that to them in the emergency room or when you get admitted, and ask them to put it on the computer, and that will work.
Are you, I'm not clear. Are you saying that the patient would tell the hospital who can get information about them? Is that what you meant?
Yes. Now, so that's why in advance of hospitalizations, it's worth doing these kinds of things, writing down who can you give information to, and having a list of it. Now, okay, let's see. What is a PULST? So a PULST is providing life support. It's a document that describes what specific things your person wants, whether they want CPR, they want to be intubated, they want antibiotics. And it's an order form where the person has to fill it out. If you're a durable power of attorney, you can also sign, and a doctor actually has to sign it. So it's like orders for life-sustaining treatment. So it's providing orders for life-sustaining treatment. It's something you should talk to with all of us should talk to our doctors about it. Okay, how do you tactfully tell the doctor to look in your eyes instead of the tablet with the chart? It's a great, it's interesting because, I teach residents and I talk about that. On the other hand, they tell, everybody's rushing. There's so much pressure. How do I tactfully say that? That's a very good question. Well, the first thing, if you have a good sense of humor, I mean, I'm not saying, I don't know if I could come up with a good joke, but if you have a good sense of humor always can mitigate those kind of things. If it's your primary care doctor, if it's somebody you have a relationship with, I probably would say something to them. How would I say it? I'd say, it depends if I really like them. If I didn't like them, I don't know, I might change doctors. But if I like them, they might say, I think you're this I think you're a great doctor, and I really want you to be my doctor. And it would really make me feel so much better and safer if sometimes you could make eye contact with me. I know you have to do all this computer stuff, but that would be helpful. That is one way I might do that. Okay, another question. And if any of these things, if you want more than I'm saying, speak up, raise your hand. It can also help to ask the nurse what to do. They may have an excellent suggestion and they may be able to advocate with MD. Absolutely. Also, you can ask the nurse to chart the issue that you and the patient are experiencing. If it's an issue that a caregiver should be responding to, for example, a pressure ulcer, wound pain, definitely. Actually, always involve the nurse in things. If you're, in who you probably should be communicating both to the nurse and to the doctor about things. And yes, nurses can definitely be good advocates. And sometimes they're not. And so when I was talking about the supervisor, the question was when the nurse and the doctor were not listening to you. But I by no means want to imply that nurses aren't incredible advocates for patients, because they are. If the patient has a large family, it would be best to appoint a family member to call the rest of the family. That's a very good suggestion. That if you're getting information, that how to get information, have one person do it. Now, if there's two people and one person has more skill with certain kinds of medical information and is not accessible to be the point person, that often happens. You know, I can't call, but I'm the one who takes care of my dad all day. One can either write stuff down or say to the person who you're calling for information, we've organized it so I'll be the point person, but we have one person in the family who has a lot of information. Can they give it to you directly? I'm not sure if this applies about residents in SNFs that usually have house. Okay, so I have been a medical director and I've worked in skilled nursing, and it is a problem. But you have the right to talk to that doctor like any other doctor. You get their phone number and say you want to have an appointment, or can you come when they're there to see your person? Now, some skilled nursings, the social service person might be the person to facilitate that. Sometimes not. Sometimes you just ask the nurse or the charge nurse for the doctor's name and phone number. If you don't get a response, because the doctors in the skilled nursing are assigned to a particular person, it will be the same doctor. They might have a team and they might have nurse practitioners who work with them. But actually, if you have somebody in a skilled nursing, that's another, just how to advocate in a skilled nursing is another conversation. Actually, wouldn't be another bad webinar. I really encourage you to make that connection and talk to them.
I would invite people now to put in the chat other subjects related to this or even unrelated. I'm thinking we should do a webinar on how to advocate for your loved one in skilled nursing, as you were just suggesting. Also to talk more about the pulse and to have a sense of being empowered legally, what that means. Big, complicated, important subject. Perhaps that's something that Daybreak will do a webinar. I would love people to put in anything that they have now or that they think of later, okay? Please do that. Thank you. Are there any more questions? You can put your hand up or ask another chat or send in questions afterward. We're so grateful to you, Dr. Landau. It's just, this subject is so important. It's not easy on so many levels. when a loved one's in the hospital. And these days, more than ever, as you say, and nobody is more upset about it than the people who work there, I'm sure. Yeah, thank you again. Thank you again.
It was nice meeting all of you, although I didn't really, but I saw many of your faces.
Thank you. And we will have this recorded, and it's available on our website, also in our newsletter. And if you can't find it on those two places, just directly contact me. If you have my address, which is just susan@daybreakcenters.org, let us know, and but we can send you this recording. And our next newsletter will feature notes about this webinar. So more to come.